Everyone, please welcome Emily and Amanda.
Hello, and welcome to the final webinar in a three-part series, An Introduction to Evidence-Based Practice, Appraisal and Application. I'm Emily Brennan, Research and Education Informationist at the Medical University of South Carolina Library.
And I'm Amanda Davis. I'm a Senior Evidence-Based Practice Analyst with the Value Institute at MUSC.
And I, Emily, work in the MUSC Library Research and Education Department, and I'm also a member of the MUSC Hospital's Value Institute. The Value Institute provides evidence-based practice education to clinicians, guides the development of evidence briefs and hospital guidelines, and helps develop clinical decision support tools such as order sets for the electronic health record. After completing this class, participants should be able to describe study designs and the hierarchy of evidence, choose appropriate study design based on question type, and apply descriptive and inferential statistics to understand research findings. There are 5 steps in the evidence-based practice process. In the first 2 webinars in this series, we reviewed how to formulate the clinical question using PICO and search for background and foreground information. We will now discuss how to appraise the evidence. So you may recall that we used mission burnout prevention as our clinical scenario. So we in the Value Institute worked with the hospital's nursing shared governance leadership on the issue of burnout. We will continue with this scenario. The Nursing Shared Governance Committee enlisted our help to explore strategies to prevent burnout in hospital nurses. Based on a literature search and further discussions with shared governance, we established these PICO elements. Our population is hospital nurses. Our intervention is online education. We are comparing that to in-person education, and the outcome we are measuring is burnout. This could be thought of as a prevention question for nurses not yet experiencing burnout, or a therapy question for nurses who are already experiencing burnout. The question first came to us as a prevention question, but we learned that there are nurses who are already experiencing burnout, so we could research this as a therapy question as well. The type of question dictates ideal study design that you should be seeking. For both therapy and prevention questions, randomized control trials are the ideal study design. Now I'll pass it off to Amanda, who will discuss article selection and appraisal.
Thank you, Emily. So I want to start off by asking, why are all these EBP tools so important? Really, it's because using literature as a shortcut helps us to solve problems based on what has worked best for other people and other organizations. So kind of like this cartoon here, we want to be using the wheel so that we're not continuously trying to go nowhere using square wheels. We want to be able to prevent reinventing the wheel and just kind of use that literature as a shortcut. So really the next step is really kind of deciding what to send. Some searches, you'll notice, will result in a small number of very targeted studies, but other times there's going to be hundreds of results that can really overwhelm the requester. So really focusing on how to curate a selection of articles that best fits the requester's needs is essential. So how do we systematically decide what are those best articles and what really should go in the proverbial trash can? This is something that Emily and I have been refining in the Value Institute through our work for years. And what you see here is kind of our article selection process and kind of the way that we work together to be able to provide a final product for our requesters. So if we walk through kind of what we've already done in the previous webinars for this course, kind of overview of what Emily just spoke about, we've already made sure that the articles that we have found are appropriate for our PICO question. we've already determined that the study design that is most appropriate is randomized controlled trials followed by cohort studies. And now we're really starting to consider inclusion and exclusion criteria so that we can identify the best articles and then critically appraise the literature. So in thinking through that process of inclusion and exclusion criteria, one of the tools we use here in the Value Institute is the grade criteria. GRADE stands for Grading of Recommendations, Assessment, Development, and Evaluation. And it's a methodology that really provides a transparent approach to grading the quality of a body of evidence and the strength of recommendations that come out of that evidence. It was developed in the early 2000s and is currently used by hundreds of international organizations for guideline development. Also, because you can see here that we kind of look at the study design, so an RCT or an observational study, and assign an initial level of evidence where randomized controlled trials are high and observational studies are low, just like in the evidence pyramid, what the grade criteria really does, it helps you to lower the quality of a randomized controlled trial based on specific criteria that you see in a body of randomized controlled trials. And it also similarly allows you to raise the quality of evidence for a body of observational studies on multiple factors as well. But when you think about those grade criteria, they also can be used for assisting with article selection and that inclusion-exclusion perspective. And this is really why. When you're looking at the first criteria, which is indirectness, really what that does is helps to identify differences between studies compared to your PICO question. So if you have a large body of literature that comes out of a search, you're then able to kind of systematically look through those studies and compare your PICO question to the population. So for example, if through your search you were interested in children, but lots of those studies were about adults, you might be able to think about putting studies about adults into that trash can because they are indirect. Similarly, when you're looking at the intervention, when you're searching, if you have oral pain medications as your goal, and when you're looking through the abstracts, you notice that there are IV pain medications that have come through in your search, you could also throw those that weren't about your intervention of interest into the proverbial trash can because they are not direct. And then finally, in looking at outcomes, if your outcome of interest is mortality, a lot of times you'll notice in the literature that they use a surrogate outcome. So for example, if you're interested in cardiac mortality and what you're finding are studies, some that are about cardiac related mortality and others that are talking about suppression of cardiac arrhythmia, that is a level of indirectness based on outcome. And so you might want to put those studies that have that surrogate outcome into the proverbial trash can. Really what you're trying to do here is to create a situation where you are trying to have studies that are as closely related as possible, because the more indirectness that is in your body of literature, so in the articles that you're providing to your requester, those indirect comparisons really kind of decrease the quality of that literature overall when you're thinking about the body of literature. And a related criteria is going to be inconsistency, because by placing indirect studies into the proverbial trash can, you decrease the heterogeneity of the remaining articles. This really helps to decrease inconsistency in the populations and the interventions that are in that remaining body of literature. Another thing to keep in mind is that your requesters may also evaluate for inconsistencies during the critical appraisal process, and they're going to be really looking at the potential inconsistencies in what you provide them with respect to treatment effect and outcomes. The next criteria is imprecision. And this is something that you may notice as you read abstracts during the inclusion-exclusion or article selection process. And imprecision, really what it does is it identifies problems with accuracy and or exactness of the data. So kind of like this dartboard that you see here, you see that the darts are kind of all over the place. So if you notice that those findings, those results are all over the place, that's going to be what's called imprecision. And that can potentially relate back to inclusion-exclusion criteria and your article selection process through sample size. So for example, if you have a search results and there are lots of studies, some of which are larger studies and some of which are smaller, and you can potentially remove or throw those small sample sizes into the trash can in that article selection process because they aren't going to be as high quality. The precision in a smaller sample size might be questionable, but if you have lots of high-powered studies, maybe those smaller sample size studies could be removed from what you provide to the requester. And also, there's publication bias. And really, this is related to identifying problems for what is actually published. Because there is consistently a difference between all of the studies on a particular topic and what is actually published in the literature. And so what you see here on the side of this slide is really what's called a funnel plot. And the top figure shows you low risk of publication bias. And the reason you know that is because the different red dots, which are individual studies, they are spread out all along that funnel. So when you see a funnel plot that looks like this, you know that that the majority of the studies on this topic have been published. So you're seeing the good, the bad, and the ugly. Whereas with the funnel plot on the bottom, you'll see how they're all kind of smushed together on one side. That's an indication of publication bias because it means that only certain studies or certain studies that have certain results are going to be found in the published literature. And when you're thinking about publication bias from an inclusion-exclusion criteria in that article selection process, one thing you can also think about here is the fact that this is a good place to take into account reputable journals versus potentially questionable journals. And when you look at the articles that are in your search results, is that something that you might want to be able to remove or throw some of those more questionable journal articles into the trash can? And finally, there's large effect. And large effect isn't really something that you're going to necessarily use as inclusion or exclusion criteria, but it is something that's good to keep in mind as you're reviewing abstracts. And large effect is really related to those observational studies I was telling you about. When you're looking at observational studies, especially meta-analyses of observational studies, there is the opportunity when using grade criteria to really highlight large effects, to upgrade, to increase the quality of the overall body of literature. So, for example, a strong effect would be, for example, an observational meta-analysis that finds that bicycle helmets reduce the risk of head injuries with a relative risk of 0.31. Now, that 0.31 shows you there's a 70% decrease. Well, if a very strong effect is even higher than that. So here you have a meta-analysis that looks at the impact of warfarin prophylaxis in cardiac valve replacement, and it's a relative risk of 0.17. So that's a very strong effect. And these are things that you can notice as you're reading and can bring to the attention of your requesters. Now, the next thing you really think about is kind of going back to that evidence pyramid and looking at what you have found and being able to kind of work your way down and see what, from an article selection standpoint, makes the most sense based on your requester's needs. So we're going to start with clinical practice guidelines. And when you're looking at clinical practice guidelines, I want to make you guys aware of the fact that in 2011, the Institute for Medicine, which is now called the National Academy of Medicine, put out a report called Clinical Practice Guidelines We Can Trust. And in that report, they really focused on setting 8 standards for trustworthy guidelines. And this is an important factor because this allows you to kind of look critically and appraise guidelines in a similar way to how you appraise primary literature. And this was the first time that there was really a standard that was set. And since 2011, the standards for guidelines have kind of been disseminated, and now the guidelines that are being developed currently are a lot more robust just because they're now held to standards. So if you're able to find guidelines, you're able to look at these trustworthy guideline assessment components and decide how much can I trust this guideline, similar to the critical appraisal process for research. And when we're going through and looking for clinical practice guidelines for our mission burnout prevention kind of scenario, our work that we did with the shared governance, we weren't able to find a clinical practice guideline, but we were able to find information that came from the Institute for Healthcare Improvement that really focused on improving joy in work, so preventing burnout. So looking at how can we turn burnout into engagement. And these are different tools that are evidence-based, high level, similar to a guideline, but more practical in nature. And as we walk down the pyramid, next we have meta-analyses and systematic reviews. And I'm sure you guys are very familiar with systematic review in the process and are engaged in the process as well. But just to kind of quickly reiterate that systematic reviews summarize the results of multiple well-designed studies, and the purpose is to provide higher level evidence for decision making. And keeping in mind that if the studies are similar enough, you can draw conclusions by pooling that data together in what's called a meta-analysis. So as you see in the figure here, you're kind of casting a broad net and then being very methodical and refined in the way that you treat what you find to be able to ideally draw even stronger conclusions using meta-analysis techniques. And one tool I want to make sure that you guys are aware of and that you've seen, I'm sure, in your search processes is the Cochrane Risk of Bias tool. And what you see here are the 2 different figures that come out of using that tool. And it's very commonly found in systematic reviews of randomized controlled trials. So they look at very specific factors and then rate them on a scale of low risk, which is green, unclear risk, which is yellow, and high risk, which is red. So if we take it back to our example for mission burnout prevention, here's one of the systematic reviews that we were able to find about our topic. And as you can see, when you think about it critically, it is a Cochrane systematic review, so you can be very confident that their methodology was sound, and they're very transparent about their methodology, even in the abstract. So they tell you very specifically about their search methods, their inclusion criteria of randomized controlled trials, and also their data collection and analyses procedures. And you'll note that they also used the grade approach. So they applied those same criteria that we've talked through to kind of determine the overall quality of evidence for this body of literature. And as you can see, only 2 studies met the inclusion criteria, so they weren't able to do a meta-analysis. And when they applied that grade approach, they found that there was a very low quality of evidence and that the results were conflicting. So now we're going to get to the real meat of critical appraisal, which is the primary studies. And when you're looking at primary literature, you really want to think about 2 questions. You're asking, are the results valid, and are the results important? And that first question, are the results valid, that's largely going to be answered in the methods section. And then the results section really will obviously help you answer, are the results important? And the reason you're asking these questions is because you want to use a critical eye. That's why it's called critical appraisal. And there are 2 types of error I want to acknowledge here. The first is random error. Random error is completely due to chance. It's going to happen no matter what you do, no matter how well designed your study is, no matter if you're looking at an experimental study or an observational study. Random error just exists, and it's due to chance, and it's accepted. It's systematic error, which is due to human influence, that we try to focus on in the critical appraisal process. That's because this systematic error, which is also called bias, can be minimized through the development of a strong trial protocol or a strong research protocol. And so that's what we're looking for in critical appraisal. How good was the study designed? How well was the study designed? And when looking through different appraisal tools, we in the Value Institute decided to adapt our tools based on the Oxford Center for Evidence-Based Medicine. Their tools were really the basis for our tools. But there are many tools available to you to go through that appraisal process. Here, this gives you kind of a good snapshot of a variety of tools for critical appraisal based on the type of study you're interested in appraising. And this comes from a 2017 systematic review of critical appraisal tools that was in the World Views of Evidence-Based Nursing. So here, this table gives you the ability to look on that left-hand side, identify what type of study it is you're interested in appraising, and then it gives you different options for what tools might be available. So if we kind of now, we are to the point where we have our tool or we're thinking about a tool, we need to know what kind of research we're looking at. And primary research studies really do divide into 2 very specific areas. Experimental studies, which are studies where you intervene in some way and then compare at least 2 groups to see what the difference was based on that intervention, and then observational studies where you really just watch and describe what happens or describe what already has happened. So let's start with experimental studies. Experimental studies in humans are also called clinical trials. And there's really 2 main types of experimental studies in the literature. The first is your randomized controlled trial, which I'm sure you guys are all very well aware of. And the second is a before and after study, which is also a quasi-experimental kind of study. And what a before and after study is it's really commonly, that technique is commonly used in quality improvement literature to assess for specific factors before and after implementation of an evidence-based intervention. So if we look at randomized controlled trials and we start to ask that question, are the results valid? There are a few things we really want to hone in on. The first is sample size. How big is the sample? Did they do a power calculation? So do they know that they have enough people in the study to be able to ensure that any statistical difference is real? Next would be randomization. And the purpose of randomization is to kind of even the playing field, because we're trying to get the same types of people in the control group that are also in the intervention group, and we do that by randomly assigning people to one or the other. Then comes blinding. Blinding is really related to, does the person in the study or anyone involved in the study know which group you're assigned to? For example, pet therapy is one of the projects that we've worked on. And in looking at the pet therapy literature for randomized controlled trials, you can't blind people to the pet therapy dog or not the pet therapy dog. You either know the dog's showing up or you don't. So blinding is sometimes difficult based on the type of intervention that you're looking at or you're using. And a related topic to blinding is allocation concealment. And allocation concealment is really a special type of blinding that applies to the person who puts the participants into the randomization process. So for example, if someone walks up, do you know, as the person doing the randomization, do you know if the next person is going to be in the control group or the intervention group? And that really, if you know, you may unintentionally impact what they do within the study. So it's really important to have that person who does the randomization being blinded as well. And kind of coming back to that randomization, the whole purpose is really to have similar baseline characteristics between the control group and the intervention group. And this is where sometimes it's good to look at the results, because the results is where the table that says, yes, they're the same, they're similar, they're statistically similar, that's going to be in the results section. But that table validates the fact that the randomization process worked, and that those two groups are similar at the beginning of the study. So you have two groups that are similar, then you need to also equally treat them for everything, for every factor except for the intervention. So equal treatment of the groups is really important in randomized controlled trials, because you want to make sure that the only thing that is different is that intervention. And then finally, looking at follow-up. Was it long enough, and how many participants actually finished the study? So when you're thinking about specific assessment tools for randomized controlled trials, the Cochrane Risk of Bias tool is a great opportunity to do that. It is really a very straightforward way of looking at the different areas where you have a risk of bias. So for example, that red, yellow, and green kind of stoplight, those figures, that's the original risk of bias tool. It has 7 domains, and it assesses those 7 domains as high risk, low risk, or unclear. Very recently, so September of 2018, they actually went about revising that tool, and it now has 5 domains with signaling questions to help you better and more fully assess those 5 domains, and then register them as high, low, or some concern. So now that we've talked about experimental studies, let's jump into observational studies. And again, for observational, we're just watching and observing what happens. So there are 4 types of observational studies: cross-sectional, cohort, case control, and case report or case series. For the purposes of this webinar, we're really going to focus on those first 3. And in looking at observational studies, it's really important to focus on data collection and how the data for each different type of study is collected. Cross-sectional studies, as you can see here, can happen at any point in time. And cross-sectional studies are really used to collect lots of data points at a single snapshot in time. And the data is collected using specific forms and specific protocols. And as you can see here on this diagram, the timeline mirrors a before and after study on the experimental side. Next is prospective cohorts. And what a prospective cohort does is it follows the same population from a specific point forward in time to see what happens to them. And the data for prospective cohorts is also collected using specific forms and specific protocols. But as you can see, the timeline really mirrors randomized controlled trials more closely. And then finally, there are retrospective cohorts and case control studies. Both of these types of studies look backward in time to determine relationships between current disease and previous exposure. The data is collected based on chart audits, previous medical documentation, or self-reports for participants. And that is why there is an added level of bias in these retrospective studies, because the tools are very different. And when you're looking back in time and thinking back in time, documentation is not as solid or as clear as it is when you're moving forward in time. So let's look more specifically at cohort studies and ask the question, are the results valid? When you're looking at cohort studies, you're really looking at sample size. Is it large enough? Very strong cohort studies are highly populated and last for a very long time. And then looking at data collection, if it's prospective or retrospective. And then also focusing on the point in disease for the participants. Do they start the study at a common point? For example, if it's a study of diabetes, are the people enrolled in the study right after diagnosis and everyone is right after diagnosis? Or are we looking at a study where some of them are new diagnosis and some have had diabetes for 20 years? You're really trying to focus in on them being at a common point in the disease. And when you think about, when you look at different critical appraisal tools, one of the tools that can be used for cohort studies is the Ottawa-Newcastle Scale. And as you can see here, it really has 3 specific domains: selection, comparability, and outcome. And there are multiple questions within each of the domains, and based on the answer from reading through the study, some of the high-quality answers are provided with a star, and you're really looking at how many high-quality answers are there between those 3 domains when you're completely assessing that study. Then there are case control studies, and as I mentioned before, case control studies are retrospective, so they have a very specific set of things you need to look at when you're asking that question, are the results valid? Again, sample size is going to matter, but patient matching matters even more. When it comes to patient matching for case control studies, you're trying to match controls to cases so that they are as identical as possible, save for the one exposure of interest. And so it's really an arduous process, and that can also affect sample size to be able to match those as closely as possible. Then you're also looking at reliability of records and patient recall, because when you're documenting, you don't know that there's going to be a study years later that they're looking at these patients. So are there holes in the documentation, or is the documentation just not correct or not adequate. And then also if you're asking self-reported questionnaires, how long ago was this? How good are patients at actually remembering what happened years previous? And then also looking at potential confounders. And confounders are those hidden factors that can make a relationship show up that isn't actually real. And keeping in mind that sometimes things you find, so correlations that exist, might have a hidden factor that's affecting that relationship. And again, the Ottawa-Newcastle Scale has different questions that are asked for those 3 domains that are specific to case control studies that can help from an appraisal standpoint. And then finally, we're to the point where if we've looked at the studies and we have agreed that they are valid because they're well designed or they're not perfect but they're good enough, then we're able to then look at, are the results important? And really when you're looking at, are the results important, you're looking at things like the size of the effect. So that's odds ratios, relative risk, hazard ratios, and the confidence intervals around those points. So confidence intervals, if they're very large, can show that there's still some questionability about that size of the effect, because it's really easy to hit a big dartboard versus a small dartboard. And then p-values, which we'll speak more about in a moment, as well as the corresponding clinical impact. But before we do that, I want to bring up this idea of intent to treat versus per protocol for randomized controlled trials. Intent to treat is when you have 100 patients in a study, 50 of them that are in the control group, 50 of them that are in the intervention group, and then when you are done, regardless of whether all 50 in each group finished the study, you analyze all 50 patients in each group. So if they don't finish the study, then they're counted as a treatment failure. And then per protocol is when they do analysis just of the patients who finished the study. And so sometimes you'll see just intent to treat, and sometimes you'll see both. And that happens a lot when there's a large loss to follow-up. So as I said, we were going to get back to p-values. So a p-value is really used to tell you how mathematically significant differences are between groups, or how significant the relationship between two things is. And when you're looking at healthcare literature, there is a threshold that you're focused on, and that's a p of less than 0.05. So what does that really mean, and how do you describe that? When we're teaching our courses here through the Value Institute, we kind of have gotten good at looking at all the different ways that you can describe this. And it's really a function of, do you need to be technical and use terms like less than 5% chance of incorrectly rejecting the null hypothesis? Or are you looking at it more from the perspective of the fact that there's a less than 5% chance that an observed difference between groups or relationship between things isn't reproducible, or that there's a less than 5% chance that the study incorrectly identified a difference between things or groups. And then if you take the inverse, it can also be described as a 95% chance that a difference between groups or a relationship between things that's identified in a study would occur again if the study was repeated. So now that we know what statistical significance is and how to identify it in a study, I want to bring up the fact that that p-value doesn't tell you anything about the size of the effect. It just tells you if the mathematical difference is real. So essentially what we're focused on now is it statistically significant and clinically important? Because that size of the effect matters for the clinically important component. So there are findings that can be both statistically significant and clinically important. That's when there's statistical importance, but the difference is clinically meaningful. And one example of that is smoking and lung cancer. So the statistics show that there's a significant increase in lung cancer in people who smoke. But there's also a clinically meaningful connection between smoking and lung cancer as well. Next is when there are clinically important but not statistically significant findings in a study. And this occurs when there's noticeable clinical impacts for patients without noted mathematical differences. And this happens when there are case studies, when a disease is rare and the evolution of the literature starts out in case studies and case series or small studies of patients. Those statistically significant findings just don't exist yet, but that doesn't mean there's not clinical importance there. And one example of that is bone marrow transplant in sickle cell patients. That started out as case studies and case series, and we've just recently gotten to the point where that patient population, that N in the literature, is big enough to be able to do statistics. And then finally, there are some times where there's statistical significance but not clinical importance. And that's when there's mathematical differences that really are clinically negligible. And this is really related to relative risk versus actual risk. And one example is blood pressure management. There was a large randomized controlled trial in 2015 that looked at blood pressure management in non-diabetics over 50 that had risk factors for cardiovascular events. They divided the patients, they randomized the patients into two groups. There was an intensive therapy group that had a goal systolic blood pressure of less than 120, and then a standard therapy group that had a goal systolic blood pressure of less than 140. The study found a 25% lower relative risk of cardiovascular events like MI, stroke, heart failure, and death in the intensive group. And it was statistically significant, but really when you looked at it, there was an 8% risk of cardiovascular events in the standard group and a 6% in the intensive group. Taking that into account with the fact that the intensive group had to take more medication and had more side effect management, is it really clinically important to hit that less than 120? Not really. And now I'm going to pass it back off to Emily.
Okay, so now we're going to bring it back to our scenario, mission burnout prevention, and briefly review the librarian's role in selection and appraisal, and also evaluate a few more studies. As Amanda mentioned earlier, the article selection process consists of finding articles that match the PICO question, identifying ideal study designs, considering inclusion and exclusion criteria, identifying best articles, and critically appraising the literature. Generally, the librarian is involved in the first 4 of these 5 steps. However, there are librarians who are involved in critical appraisal, in medical education or resident journal clubs or evidence synthesis services. I think the trick is to find your niche based on your skills and institutional expectations and opportunities. So let's look at a few articles that we discovered through our search strategy. So this first one is a randomized control trial, which is the ideal study design for a prevention or therapy question. In this study, their objective is to compare mobile video conference-based intervention versus in-person versus self-care for stress reduction and resilience. This is similar to our PICO question, except that their population is all employees rather than just hospital nurses specifically. So this relates to indirectness. The sample size is 81 participants, and 71 of the 81 completed the study. Participants were randomly allocated to one of the 3 interventions, and blinding was not possible. The authors state that they found statistical effects on perceived stress, but no significant differences between mobile video conferencing and in-person conditions. However, they do not include those statistics in the abstract. Participants were followed up 4 weeks after the intervention, and the authors indicate that a larger sample size and longer follow-up are warranted. And so although there are limitations, because this is the ideal study design for our question, and it fits our PICO question pretty well, I would probably still include this in my keep file. The next article is a prospective cohort trial, which is the second most ideal study for prevention and therapy questions. So their population was a variety of health professional students and residents, which is more aligned with our population of interest. They studied an online intervention for stress, mindfulness, and confidence in providing calm, compassionate care. 60 participants who engaged in the online intervention were similar at baseline to the 43 who did not. Participants completed pre- and post-intervention surveys and were followed up at 12 weeks. Participants who completed the online intervention showed significantly greater improvements in measures of stress, mindfulness, and confidence. The final article that we will evaluate is a case control study. This is an interesting study because the authors performed a case control study within a cross-sectional study. They surveyed 196 caregivers on exposure to violence, and that's the cross-sectional component. From that, they identified 20 caregivers who were exposed to violence and matched them to 20 caregivers who were not exposed to violence, and that's the case control study component. There were differences regarding burnout, but not regarding other outcomes such as coping ability and character aspects. So if we think back to the steps of evidence-based practice, the last steps are to apply the evidence and assess the results. For mission prevention burnout, Amanda and I performed a literature review and developed an evidence brief and shared that with the Nursing Shared Governance Committee. They then worked with the Office for Health Promotion to develop a series of online educational modules focused on burnout prevention and treatment in MUSC's Employee Wellness Program, Imagine You. And that's what you see here. And these are the references that we used throughout our presentation. And now we're going to open it up to questions. So we do have a few questions here that we'll answer. So the first one is, where do you place critically appraised topics such as up-to-date in the evidence pyramid? And so critically appraised topics themselves are not primary literature, and they themselves would not fall in the evidence pyramid unless you were going to put it as expert opinion. So I think you could either consider that background information or expert opinion, but really what you'd want to do is look at the primary research studies that are referenced throughout that summary and then critically appraise those separately. So the second question says, I have not used the tools, example, Cochrane or Bias tool. Which one is the most used in your opinion for most study types?
And really, my best suggestion there would be to go to the article that I referenced that showed the table of the different tools from that 2017 systematic review of critical appraisal tools, because there's different types of tools for different study types. So, for example, because the biases the potential biases you're looking for in randomized controlled trials are so different than for observational studies, you're really going to be looking at least 2 tools.
Okay, next question. How many articles did you send to the Nursing Council for reading? So we do so many evidence briefs, so I can't recall the exact number, but generally we send about 20 max to the requester, and then Amanda will put those in an evidence brief or whatever, tool that they want that to be in. Mm-hmm. Do you have any recommendations for further reading on the topic? So we would recommend going back to the reference page because those were kind of like our top hitters and our most recommended resources. The next question is, do you know why some evidence pyramids have guidelines at the top while others have systematic reviews at the top?
And there are multiple factors that could relate back to this, but one of the most common that I've seen is the fact that it used to be that originally the evidence table randomized controlled trials were at the top. And as the systematic review process has become more and more prevalent, but also more and more methodologically sound, systematic reviews have become that top tier. And now with the evolution of the IOM 8 clinical practice guideline assessment standards, that is where now we're starting to see an evolution again, where based on that expectation of rigor, some people have put clinical practice guidelines onto the top of the pyramid, because if it is a rigorously designed clinical practice guideline that we find to be trustworthy, then it can be even more useful than the systematic review that was used to decide the clinical practice guideline. So it really kind of depends on the purpose of the tool, which one's going to be more prevalent and or a better fit.
Okay, so we want to thank you for watching this webinar, and please reach out to us with our emails on the slide here if you have any further questions on this topic.
Thank you.
Thank you.
And I would like to thank you both, Emily and Amanda, so very graciously for recording this webinar for me and doing this webinar as a second time. So I greatly, greatly, greatly appreciate it. So thank you both.
Of course.
You're very welcome, Tony.